Good afternoon, everyone, and welcome to this Hospice News webinar sponsored by Citus Health. Teamwork makes the dream work, helping interdisciplinary teams better serve their patients and family caregivers. Today, more than ever, it's important to enable close communication and collaboration within the IDT to best support patients and family caregivers. Research shows that family caregiver satisfaction with your organization's communication can make or break your CAHPS scores. The problem is IDTs may not have the right systems and processes in place to properly support the level of communication they need to be successful. Our panelists today include Maureen Kelleher of Black Tree Consulting. Maureen has more than 20 years of experience in healthcare, with 17 of those years focused on hospice and palliative care. Her background includes family practice management, hospice nursing, palliative care, multiple hospice executive directorships throughout the United States, as well as hospice consulting. She also serves on the Ethics Advisory Council with the National Hospice and Palliative Care Organization. Also here is Stan Massey, partner and lead consultant with Transcend Strategy Group. Stan brings 40 years of brand improvement and marketing experience today. For the past 18 years, Stan's been developing effective communication strategies, creative concepts, and attention-grabbing campaigns to successfully build brands for providers of home-based care and senior care. Guided by research, Stan skillfully crafts strategic marketing plans and messages that speak to their target audiences and yield exceptional results. And last but not least, of course, is Melissa Kozak, co-founder and CEO of Citus Health. As a post-acute care nurse in New York City for 8 years, Melissa saw firsthand the communication and care coordination challenges with connecting frontline clinical teams with office teams and partners in home-based care. She also recognized that providers were relying on outdated technologies to communicate with family members and caregivers. She teamed up with a leading healthcare technologist and founded Citus Health in 2016 to tackle these challenges. Following these presentations, there'll be a question and answer session. Participants can submit questions using the designated box on the GoToWebinar app, and slides and a recording of the webinar will be made available following the program. So thanks to each of our panelists for being here. I will let you take it from here.
Thank you. We go to the next slide. So my role in this presentation is to help people understand the expectations of Medicare in hospice and the role the IDT and the whole team plays with the family and the caregivers. We're using technology more and more, EMR systems, and questioning how does that exactly support the team and the family caregiver communication, and what to expect when communication is firing on all cylinders. Next, please. So CMX expectations for the team approach to the IDT collaboration with family caregivers. Medicare expects hospices to really use best practices. So we're going to go over some of the challenges, some of the roles the technology provides to support the team and families, and again, what to expect. Can we next slide, please? Go ahead to the next one. One of the biggest expectations is that Medicare expects hospices to involve the patient and or the family or caregivers in the development of the care plan. Sometimes this can be a bigger challenge than we realize, but we have to be making sure that care plans focus on the needs of the patient and the family, how to educate them on what's going to happen, the disease process, how to manage the symptoms, because in the end, it's the family and the caregivers who are providing the round-the-clock care. The hospice comes in to provide that education, to provide the support, but they're not there 24/7. Much unlike some of the expectations of families, we go in and we talk to families, we create the care plan, but they have to be in agreement with that care plan or something's not going to work. And if you can't communicate with patients and families, there's really no way to have a high quality, enforceable, active care plan. Next slide. So the expectation to educate patients and family about the roles of disciplines. Hospice has been around since the 70s, and patients still think that social workers in hospice are there to take over control of everything. They're going to take over their finances. They're going to take over their children. They're going to, they have these misconceptions. They also have misconceptions about spiritual care. And they think, oh, you're just going to evangelize to me. I'm not Christian. I'm this. I don't want a Christian minister coming into my house. We have to be able to educate people on what each discipline is going to do and what it means, and especially on existence and existential crises. We have to be able to understand that in order to educate the patients, because that existential being exists across all disciplines. And so we also need to then create a plan of care that includes nursing, social work, spiritual care, volunteers, CNAs or CHHAs, depending on what state you're in. It also includes the community resources. Who in the community is going to be supporting this patient and family? So Medicare expects hospices to put all that together and then be able to support the family in making some of those decisions that are coming. Next slide. Thank you. Some of the considerations when you're dealing with patients and families. First of all, most of hospice patients, in fact, all hospice patients, have never experienced their end of life before. They get one shot at this. We get one shot to go in and help this journey they're going to go on. And their families, in most cases, have never experienced somebody who's dying. They may know somebody who's died, but they have not experienced that caregiver role at a patient's end of life. You have to take these things into consideration because it's a scary time for patients and families. We come into a patient's home and we're telling them everything hospice has to offer, but it is impossible for somebody who's in a crisis brain set to remember everything you're telling them, even if you give it to them in writing. They're not going to remember what papers they're signed. The standard is people will remember about 10% of what you tell them. So in order for them to remember everything you've told them, you have to be able to tell them the same thing over and over at least 10 times. So coordination with communication with your team is incredibly important. You don't want your nurse saying one thing and your social worker saying something else, because that's just going to cause confusion. And we want to make sure that questions are answered before they become a problem. Patients and families need to know what to expect. If we're only going out and seeing somebody once a week, are we really answering all those calls, all those questions? How many calls does a nurse or a social worker receive from a patient or a family member during their shift? I know plenty of nurses who are driving from one patient to another and they have to pull over because they're getting a phone call from a family member who's in crisis, and well, the nurse doesn't necessarily consider it a crisis. Could be something as easy as I've run out of supplies, but to that family member, it's an emergency. So communication, you have to have really good communication and the ability for patients to feel like they're being heard, family members feeling like they're being heard. Next slide. Again, patients and families are in a crisis. It's something they've never experienced before. They want to know who they can talk to. They want to know how they can get to them. They want to know how fast they're going to get a response. Consider the time now. If you are in hospice right now and you are the case manager or the social worker, how long does it take for somebody when they're trying to get a hold of somebody at hospice to get to somebody who can answer their questions? In most cases, you're calling into a main number, you're getting somebody who's answering that main number, and then they take a message and then they send a message to the nurse, and then the nurse has to call back, or they don't have the right number. And by the time they finally call back, the reason for the call has elevated because they've had to wait so long. And then think to yourself, if someone you loved was actively dying and you were frightened by that process, how long would you want to wait to get a hold of somebody to help you through that? How many calls would you be willing to make to get to that nurse? And I can tell you, if you're waiting, every minute is really an hour in your brain. So, keep those questions in mind when you're thinking about communicating with your patients and families. Next slide. Our IDT process, when we get together every 14 days, everybody comes together in a conference room, the social workers, chaplains, everybody's there. You go through the list of patients, who's going to recertify, who's new, who's got new problems, any medications, any missed visits, changes in condition. We're talking about the patients, we're talking about the caregivers. Are they causing problems? Are they easy to talk to? We're having all of those. It can sometimes turn into a venting meeting. But what about the family and the patient in that process? We then, if you could go to the next slide, please. Then we're talking about the plan. We're going to get new orders. We're going to come up with this new plan we're going to do to help get to these goals. Then the nurse calls the responsible party, and what if they don't agree with those plans? What if they don't agree with putting the patient on morphine? Now the nurse has to call the doctor back, wait for the doctor to call them back, then call the family back, make sure they agree with it, then create a new care plan, and then put the steps in place. It's just a lot of time and effort when in today's age, it doesn't need to be that complicated. Next slide. So there are studies that have shown that families who feel a greater sense of satisfaction when they're involved collaboratively with the team and in the planning of the care. So again, think for yourself. You go to your doctors. Do you want them just diagnosing you and giving you medications and telling you this is what you have to do and not asking if you're willing to participate in that? Do you want them to ask you questions about what you're going through? Our satisfaction scores in hospice, this is directly impacted by the way we communicate with our patients and our families. So now they're doing studies and they're showing that the scores actually improve when you include families. And I get it. To try and get 30, 40, or 50 patient families into an IDG meeting is not realistic. You'd be there for a week. But finding ways to communicate with them real time or include them in the process before decisions are made is critical to the satisfaction and the experience these patients and the families have during this journey at the end of life. There's also clinical complaints. Through 17, 18 years I've been doing this and running programs, one of the biggest complaints I hear is staff can't get through to the people they need to get through to. They can't reach family members. They can't get to a doctor. Doctor doesn't call them back till 8 o'clock at night, so they can't get orders. The patient's in pain. Now with COVID and the public health emergency and everybody is trying to do telehealth visits, you're calling somebody's phone to do a video. What if they don't answer? I can't tell you how many times social workers are documenting they didn't answer. We set up this appointment, they didn't answer. So now you don't have your visit. Yeah, there's better ways. There's faster ways to communicate with people. And there just haven't been in the past really good, fast and efficient methods and technology for hospice. So at that point, I'm going to pass this on to Stan so that he can continue on with this.
Thank you, Maureen. If you want to go to the next slide, please. So I want to take just a few minutes to talk about best practices your teams can actually apply to engage with family caregivers. And when I talk about best practices, this is based on over 20,000 surveys nationally with family healthcare decision makers that we've conducted over the last 18 years. And then another 18 years in conjunction with that of doing campaigns and messaging and strategies to connect with family caregivers in a very meaningful way. Next slide, please. So why do we really want to focus on caregivers as such a vital target audience included for your marketing? I would love to share some data with you that really supports why this is really more important now than ever. Do you want to go to the next slide, please? Just this past April, my company transcended a national survey of 1,000 family healthcare decision makers and caregivers. And 99% of those 1,000 have already actually had real-life experience in providing or arranging care for a loved one. And it's not a big surprise, that first bullet, to say that COVID has completely changed their opinions. That was the survey's wording, that COVID had drastically changed their opinions about the best way to care for seniors, 65%. The change really landed squarely in the favor of preferring care at home, keeping their loved one at home where they feel in more control. 60% said they were now more confident that quality care can be provided in the home, and 38% said they were more likely to use in-home care services in the future. This was contrasted with the other side of the coin of 51% saying they were less likely or definitely would not use in-facility care if they had the choice. Now, sometimes families do not have a choice and a loved one needs to go into facility. But now more than ever, there is this want and need for home-based care, and there's really this desire to get assistance with that care because, as Maureen was talking earlier, this is a crisis situation. Families are often thrust into caregiving that they've never had to do before, especially in such a hands-on way. And the other big thing, and I'll share some other data about this, as you well know, it is often very difficult for patients, their loved ones, and their referrers to admit someone is dying. That's why hospice length of stay is way lower than it really should be for the patient to get the best quality of care. What we found out through experience is you really can't change that mindset too much of families. But when you appeal to the caregiver and helping them with this labor of love that's still very daunting for them, they will raise their hand sooner for help and say, I might want to openly admit that my mom or my spouse is in the last months of life, but boy, do I need help now. And we've seen them engage with hospice providers much earlier and directly impact length of stay in a very significant way. And I'll share some data that support that at the end of this presentation. Next slide, please. Just to further support this point, there is this growing need. A study that was done by MIT and reported in Reuters in 2017, this was their prediction. They said that by 2020, more than 100 million Americans would be providing care of some degree for a loved one at home. And we have indeed hit that mark. They also said that by 2030, there will be a national shortage of 151,000 paid direct care workers. Fewer people are going into professional caregiving. And that shortage is going to result in 3.8 million unpaid family caregivers spending a significant amount of their time to provide care. And then by 2040, that shortage of paid care workers was going to increase to 355,000, with 11 million unpaid family health care givers picking up the slack. So families want and need you now more than ever. And this is a trend that is only going to grow and deepen as we baby boomers age and need more help, and the preference is to care for the person at home. Next slide, please. To further support this is just one small sample. I talked about the 20,000 plus surveys that we've done. This is just one example, but it's representative of very similar results we've gotten all over the country. The survey question, I'm going to read some benefits that hospice care typically provides. Please tell me which benefit would be the most valuable to you if you were caring for a family member at the end of their life. And you can see that the family always tends to put the patient first. It is a labor of love, and the number one priority It's helping keep the patient comfortable, keep their loved one comfortable. But tied with that is this desire for access to you 24/7, even if just by phone, for assistance. And being taught how to be a caregiver came in next, and then providing spiritual support. So you can see 3 of the top 4 answers, one of them is directly about the patient. The other 3 have as much to do with the family caregiver as the patient. Now, there is some shared benefit there, but there really is this value that caregivers voice themselves, saying that they really want help at home. So how do we act on this? Next slide, please. Again, it is a really good practice to actively and proactively target family caregivers in your marketing plans. When we talk about family caregivers demographically, we've always defined them as adults aged 45 plus, skewed toward women. And you don't have to have the budget that you used to. Back when mass media was our only option. If you have a sizable marketing budget, there is absolutely nothing wrong with still using mass media tools like local TV and radio, because we've also seen that consumers in general have very low awareness of who the providers of care are in their communities, and they really don't know the difference between providers and their brands. So being able to create awareness for your organization and differentiate yourself from your competitors is really important. So mass media tools like TV, radio are very helpful to do that, but they're also expensive because of the media costs. It is very effective these days to use social media, and I'm talking about paid Facebook advertising, paid social media, not just your Facebook page. Facebook's algorithms, I know that you experience this as a consumer. As a consumer, I find it's a little scary that Facebook and my smartphone know what I'm doing. It seems like every single second of every single day. They track not just my Facebook activity, but all of my online activity and behavior. I also have clear evidence that Alexa is listening to me all the time, and I'm being fed information based on conversations I've had that I thought was the privacy of my own home. But we won't go into that into detail. Just, I know that you're aware that the algorithms are getting more sophisticated every day. The beauty of that as a marketer, though, and the benefit as a hospice provider is that you really can target this audience at a time when it's going to be relevant and meaningful in their lives. It's not every day that you need a hospice care provider, but based on other online activity, social media can target and track and deliver messages that are going to be really helpful and help connect caregivers to you seeking your guidance and your assistance. The same with paid Google search ads. You're all aware that if you pay a fee, you can come up to the top of the search results on Google. Well, it's more than that, because it's actually knowing the right keywords, and there's a science to it. That when families are searching for help, you can pay and get to the top of the results. And the thing that's really important about both the social media platform and the paid Google search ads is that they are going to give you a way to connect caregivers directly to more information on your website. And I'm going to get to that in just a moment. The other way to do that is to do digital banner ads. I know a lot of times we tend to ignore those banner ads that pop up on websites, but if your messaging is relevant to the audience, and again, you can hire professional digital media ad buyers to help you with this, and they can help make sure that your messaging is being delivered to the audience at a time that's very relevant to them. The beauty about all of these digital platforms is, unlike mass media, you can set budget ceilings and not surpass whatever budget you want to establish. So you can at least have some presence on Facebook, Instagram, and paid Google search, and some digital banner advertising as a bonus. But it's a way to really make sure that your branded messaging that helps explain how you support family caregivers at home can reach them at a time when they are really looking for help. Next slide, please. The other really important aspect of this, I mentioned that all of these tools can help drive target audiences to your website. One thing that you need to make sure is that your content on your website is really going to be helpful to your target audience. So make sure that you have very relevant content up here. I know people have their websites are in all kinds of different states right now, but one gut check that you can do, and I would say that this might be true for at least 80% of you listening today. But if you look to your website right now, it's highly likely that for 80% of you, the very first navigation button on your main nav is literally the phrase "About Us." And so we're always so eager to tell people what we can do for them that we forget to put their needs first. So a really good practice is there's nothing wrong about having all the information about you and your mission and your board and your expertise, but prioritize the audience's needs first. Make sure that things are very prominent, that you have helpful information for caregivers, including caregiver tools and training, and things like you can create one-page downloadable PDFs with caregiver tip sheets, and even do like instructional videos. Especially with COVID, it's become very acceptable. You don't have to all be Steven Spielberg to produce our videos now. You can create very high-quality videos off of your iPhone or smartphone, and having your staff, again, promoting your expertise through simple instructional videos on activities that they know are going to be helpful to caregivers at home, that they get asked about all the time, is a really great way to not only provide great information and training, but to promote the expertise of your exact team. And just a couple quick examples of one provider that's doing this. Next slide, please. Northern Illinois Hospice, which is in Rockford, Illinois. They very recently redesigned their entire website, so you can see that in their navigation, honoring patients is the very first main navigation button, and then support for caregivers is number 2 with a drop-down menu with frequently asked questions and caregiver resources. You can see in their case, About Us is in the secondary navigation in that blue bar above. But you can just see coming there as a caregiver, you could see that there's something there for you right away, right on the home page. And you can drop down menu to use. And then the next slide, please. And then going to that caregiver resources page, these are all very easy to access, downloadable PDFs. So this isn't the whole page, but you can see it's divided by topics, caregiver tip sheets, and this is just one very practical way to rearrange your website content. And you drive people there through the social media, Google paid search, and digital platforms, making sure that you connect with them and provide very useful information that they will greatly appreciate. Start building that relationship to really connect with family caregivers in a way that's so meaningful to them. And with that, I will turn it over to Melissa to talk some more about how technology can further the relationship with family caregivers. Melissa?
Perfect. Thanks, Dan, and thanks to both Maureen and Stan, my co-presenters. Maureen, really for talking about CMS expectations and describing the friction in the communication process. I experienced it firsthand and really understand, as many of our viewers probably do. And Stan, the great research Transcend has done on the family caregiver, and talking about the need for better resources for the family caregiver was really terrific. So I am going to be talking about the role technology can play in supporting the IDT and family caregiver communication. All right, and so you can go to the next slide, please. We did some research of our own over the summer, researching family caregivers, and when we asked them how valuable it would be for hospices to communicate with them in real time through a digital platform, you can see that almost 70% said it would be very valuable, and a full 95% said it would be at least somewhat valuable. This really isn't that surprising, especially after hearing, Stan discuss what matters most to family caregivers is, helping the patient be more comfortable and being available 24/7 for assistance. In order to help a patient be more comfortable and for the family caregiver to be available to support the patient, they need direct and timely access to their care teams, right? If a patient needs an adjustment to their pain meds, or if the patient, let's say, they have a wound that's worsening in the middle of the night, or even something simpler, just like coordinating a visit with a nurse, right? So, but it's also not surprising because today's family caregiver is definitely more tech savvy. These caregivers are using technology in many aspects of their lives, and that is setting the expectations that convenience and fast access should definitely be available in the healthcare setting as well, particularly for such a serious time in their lives. So it really seems from our research and everything my colleagues have said here is that the missing ingredient in hospice communication with family caregivers is that ability to communicate in real time via a digital platform. But it also means that care teams that employ the right technology to better serve the family members can also become more efficient themselves by improving their own communication and collaboration. Next slide, please. So let's talk about that, because we learned earlier from Maureen that CMS expects hospices to develop a plan of care that includes all disciplines, right? So nursing, social work, and spiritual. And some of these stakeholders are in direct contact with the family caregiver, and some are not in direct contact, but they need to stay connected to their team members. And of course, the traditional methods of care team communication Maureen outlined, I'm all too familiar with. These in-person discussions, which is certainly not the best thing necessarily right now. Phone calls, emails, none of them are really real time enough to handle the dynamic and ever-changing needs of the hospice patient. And then, of course, you have some stakeholders that are external partners, right? Like physicians and DME partners. So, we can think of situations where you need to increase the dose of morphine for a patient who's experiencing pain. And I've seen it firsthand. The family caregiver needs to get in touch with the nurse. The nurse then needs to get in touch with the physician. That is not happening instantaneously. Then there has to be a call to the pharmacy. This was previously discussed. I've been in patients' homes too many times waiting on hold with the doctor's office in order to get that order, where that family member is just waiting anxiously to get an update on what's happening. And, even if it takes 2 phone calls to coordinate these things, that definitely can be 2 phone calls, too many, since delays in communication during end of life care not only cause the anxiety for the family caregivers, but potentially pain for the patient. So, this is definitely what inspired me to leave traditional bedside nursing to start a software company. And I can tell you that today's more sophisticated solutions can instantly connect clinical teams and physicians and partners and all to just quickly coordinate this care securely through things like messaging. Next slide, please. Again, not surprising, when we surveyed family caregivers, they told us the #1 thing they wanted was an immediate response to an urgent need. As clinicians know, this can make all the difference in the world. As Maureen gave the example of the nurse driving in the car, and I live in New York City, so I would be on the subway getting calls from family members, but I would also often give out my mobile number, right, to family members. And they would reach out to me for an urgent or a perceived urgent matter, but I wasn't on call every night. And so sometimes I wouldn't get back to them in a timely manner. And if that, unsecured text message went unanswered, it wouldn't escalate to somebody else who was on call. The next alternative, the family member would go ahead and place a call. Maybe an answering service would pick up who's not staffed by a clinician. They're literally just taking a message, passing it hopefully to the right team member, but more times than we'd like to say, it would be passed to the wrong person who would then have to find the right team member. And I mean, even just saying it right is a lot. And again, anxiety is building. And so, when we talk about the role of technology, I think this is a great example of a complex process that doesn't have to be. So, if the right solution is in place that has role-based message routing, And what that means is the message goes to the right team member based on the need, and that they're on call. And auto escalation functionality, meaning that if a message goes unanswered for whatever reason, there's a threshold of time in which that message will then escalate to another team member, like a supervisor, ensuring that a response, is given to these incoming concerns. It was definitely heartbreaking to see how many times the caregivers of my patients would resort to calling 911 or bringing their loved ones to the ER because their question wasn't responded to quickly enough. And we all know, especially in these times, sitting in an ER waiting for care is the last place we'd want our family members to be. So simple solutions can go a long way. Next slide, please. The role of technology. So communication can go beyond just secure care team and family member messaging, although that is a very important point of the process. A comprehensive digital patient support platform should be able to send assessments out proactively to family caregivers. It's almost like outbound triage. So you can send daily check-ins to the family caregivers. Maybe the patient has CHF and you're just sending a quick assessment. Have your ankles swollen? Have you gained more than 5 pounds? Are you short of breath? This could really help to assess, who might need more immediate help. It can be time savings, right? More efficient than calling. These assessments can ask about pain levels, medications, a lot of use cases, even help to prepare for a planned visit or pre-CAHPS score surveys. And then another component of this is paperwork. I know highly trained clinicians should be doing highly trained clinician work, and chasing down signatures is not that. So solutions that can capture electronic signatures on things like ABNs and EOBs and MD orders, either if the end user has access to an app or doesn't want to, let's say, register for another portal. We all know physicians don't want to register for another portal, but what if you could send them a secure SMS or in their email, a magic link where they can open up an order and sign it electronically. This can really help to start care, to continue care, to make sure care can be billed for, and prevent a lot of delays as well. Next slide, please. Thank you. The second highest rated activity by family caregivers is the ability to conduct a group chat between clinical staff and the entire family. As was mentioned earlier, it's not possible for a person to retain all the information given in one meeting, especially when they're overwhelmed by their loved one's end of life. There's many questions that are going to come up that require answers, and today's family caregivers are shouldering an increased burden, between work and family and maybe working from home and schooling from home, right? And now they're caring for their parent in the hospice setting. They also may be the point person between the hospice provider and their entire family, and their family could be thousands of miles away. Some of them may have, a different perspective on whether to utilize the hospice benefit, and certainly all the family members have different questions and need to be kept in the loop on their loved one status. So solutions that can offer secure group messaging that allows the nurse, the social worker, or the aide even to update family members on daily activity of the patient. Even something as simple as sharing a secure picture, of their loved one or conducting a video chat. And then of course there's medical directors, right, who have a ton of responsibility yet very little time. However, family caregivers do want more out of the relationship with them, and technology that enables a video face-to-face interaction, for example, rather than a phone call, can result in a more personal relationship and assurance that the medical director is available for the patient. And those video visits can enable the medical director to meet with more patients and family caregivers, even on the fly. And they can do this from their office or home, and it makes it an extremely efficient way for that medical director to expand her or his reach into the census. You know, I can imagine how good family caregivers would feel just being able to have that one-on-one. I mean, sometimes that's all it takes to prevent them taking their loved one, you know, to the ER. If they can have that one-on-one and see the medical director, very beneficial. Next slide, please. All right, so I wanted to circle back to Maureen's comments earlier related to CMS expectations, that hospices provide education to the family, and you know, also Stan talked about this, and this education could be about the patient's disease, the management of their symptoms, medication, equipment, all sorts of things. And you know, with knowing that family caregivers care most about helping the patient be more comfortable and being available 24/7 for assistance, in order for those things to happen, these family caregivers need to have on-demand access to education for their loved ones through an education center, right? So they have fast access to information to provide maximum support. Stan showed the hospice that has great information on their website, and they definitely do. But imagine providing that same type of information in a digital education center that can be accessed from any device, anywhere, you know, as long as you have access to a smart device. And, you know, look, as discussed earlier, the family caregivers of today are more tech savvy, so they likely do have access to, you know, a smart device, as we all do. And it really then provides more of a self-service opportunity for those family caregivers. When they're empowered with information, they're less dependent on getting the call back from their nurse, for example. They'll also have a digital record of all the conversations they've had over the platform, that they can, you know, easily go back to that chat history and the documents all in one place. And when they get the CAHPS survey, they will be able to look back at the digital record to see that you took care of them. And, you know, hospices can be very deliberate with the information provided around, you know, education, training, spiritual and emotional support, which could be logged and a nice history there. All right, next slide, please. So now let's walk through the positive impact that your agency can experience when you're firing on all cylinders, right? So when you utilize better technology and process to increase care team collaboration, coordination, and family caregiver communication. Next slide, please. So back to the research we did over the summer, when we asked family caregivers whether they would choose one hospice over another based on the ability to have more real-time communication, 78% said yes, they would. That number still blows me away, but it makes sense if you think about it. You know, you're choosing between hospice providers for the first time, and you have to figure out which one's going to do a better job. And, you know, wouldn't you want a provider that could communicate with you in real time in a format that you're accustomed to in other aspects of your life? Like other consumer categories, hospices need to communicate with their consumers in a way that's most comfortable for them. And the next question we asked was whether family caregivers would give their hospice providers higher satisfaction scores on their CAHPS surveys if the hospice had real-time communication capabilities via digital platform, and 80% of them said absolutely. So, you know, given everything we've just shared with you, it also makes sense that they would feel more taken care of during, you know, the toughest time in their life. And with these significantly positive answers, it's really a no-brainer, you know, to us for hospices to invest in modern technology that enables real-time communication. Next slide, please. So we know that CAHPS scores will be used in various publicly available publications like Hospice Compare. Your referral sources use Hospice Compare to determine who to send patients to. And, you know, today's more savvy consumers are fully aware of the resources available to them online to help make decisions like this. So this is a concrete example of how technology can directly lead to a better perception of your hospice. So actually now I'd love to ask Maureen a question. With your experience, what do you think CMS is looking for when it comes to surveying family caregivers?
So when they survey, there's a manual out there called the State Operations Manual, and it's a guideline for surveyors. And at least two of the guidelines directly involve how do you prove that you're communicating with the family, and how do you prove that they're involved in the plan of care. Now, I've seen some EMR systems that have a checkbox, but what does that mean? So the conditions of participation 418.56C2 says that IDG needs to be proactive in developing each patient's care plan. How do you prove that? So you have a care plan. Are you changing it? Is it a fluid care plan? How are you proving you're communicating with your patients and families? And the decision should be reflective of the patient's preference and the family preference. So if you have a patient and you have what they call cookie cutter care plan, so everybody has the same care plan, and all you're saying is pain should be tolerable for the patient, and they'll verbalize that it's tolerable. What does tolerable mean to that patient? There are some people out there who, if their pain's at a 10, they say, if you can get it to a 6, I'll be happy. And there are other patients like me who say, I want it 0. I don't care if I never wake up again. So I just don't want to be in pain. But if yours is always, well, 4 is our marker and we're not going to do anything unless it's over 4, how are you proving to Medicare during survey that you're including the patients? Same thing with documenting patient and or family's level of understanding and involvement. Again, there's check boxes saying, yeah, we taught this, we taught this, we taught this. But did they understand it? Are you documenting that they were able to verbalize all the information back to you? Are you demonstrating that during your visits, you're reaching out for that Gone From My Sight book or When Death Is Near book, and you're actually walking through the steps with them? That's, if you're not documenting it, and going back to nursing 101, not documented, not done. So if you had documented, how are you proving to surveyors that you're actually including people into these care plans? So that's one of the biggest things. And surveyors are looking at it, especially now that more people are going to video telehealth with COVID. You can't just have a checkbox and a blanket statement saying, yeah, I met with them over the video chat and everything's fine.
Right, those are great points. Yeah, I mean, our research also showed that 57% of family caregivers said that hospices needed a lot of improvement when it comes to these buckets, and that getting timely help was the one family caregiver said that hospices need the most improvement on. So, Stan, I was hoping maybe you can talk to an example of how someone might compare a hospice based on publicly reported CAHPS survey results.
If you want to go to the next slide, all of you, I'm sure, are familiar with the Hospice Compare information. And next slide, please. So we know that the family surveys go out and the data gets compiled into the Hospice Compare reports that are available online. Next slide, please. I'm trying to get to an example that we have in this deck. You want to go to the next slide, please? Melissa, were you wanting to cover some of this? There's what I was looking for. Thank you. The national average is with the two lowest categories, and you can see on the chart on the right, and they're often tied at exactly the same. There's 1 percentage point difference. But training family to care for the patient and help for pain and symptoms are typically tied for the lowest. You can also see at that top bar, communication with the family is barely over 80%. And when you look at the highest scoring categories being over 90%, that's a significant difference. So using some of the tools and techniques that we've covered in this presentation today, you could see the impact that you could have on really elevating those scores. If you are in touch constantly, if you are setting expectations and being able to respond more quickly if there is a situation with pain and symptoms, helping manage families and patients' expectations of the pain management that we can provide. There could be a very direct and rather quick uptick in these responses based on the tools and techniques we talked about today.
That is some real powerful data there, Stan. Thank you for sharing that. And I think, you know, it really makes the caregiver voice come through loud and clear. So thank you for sharing. And I want to thank both you and Maureen for presenting with me today. It was great discussion, and I'd love to hand it back over to Jim for some audience Q&A.
Thank you so much.
Actually, can I do one more before we do that? Can I do one more slide before we do that? That one, thank you. I mentioned earlier, I just want to show some real data of a provider that took this approach. And that year one is actual data. And this is only from the family self-referral category. So this is not the overall census and length of stay. But you can see when this provider, and they're in a very competitive market, they typically have anywhere between 25 and 30 hospice providers that they're competing with. And you can see in this chart how their admissions from family self-referrals more than doubled in 4 years. Year one was before the campaign, but you can see how that went from 205 to 444. Look at that increase in length of stay, and that's what I was talking about earlier. With caregivers raising their hand earlier, the average length of stay from this category of family self-referral went from 33 days to 87, nearly 90. And then you can see how that impacted patient days and the revenue for this particular provider. So it's just one example. We've seen it repeated with providers all over the country, but this is really the data proof that shows that this approach can work if done well.
Yeah, I apologize for skipping over such an important slide there, Stan. Thanks for presenting that one. Jim?
No worries.
Excellent. Thank you, Stan. Thank you, Melissa. Thank you, Maureen. This was a very insightful discussion, and it's great to have you here. We'll now get through as many questions as we can in the time we have left. Again, listeners can submit questions via the GoToWebinar app. And please note that slides and a recording of the webinar will be distributed at a later time. So our first question is directed at Stan. And that is, what if a hospice doesn't have a big budget for marketing to family caregivers?
Great question, Jim. The one slide that I was talking about, some tools, I would highly recommend focusing on social media and paid Google search advertising. The reason I say that is because they have very controllable cost ceilings. There's a science to the way that you put those materials together that they can be very effective. That you don't have to surpass a budget ceiling, and you also pay by click-throughs to your website. So you're actually paying for actual response to the ads, and you know that it's driving traffic to your website that will help build that relationship. The budget thing I know is a very real priority, but if you would emphasize those two routes, paid social media and paid Google search advertising, you can get a lot of traction without a lot of money.
Thank you, Stan. And Melissa, there's a question for you that came in. Is there a limit to how many users can be on the Citus Health platform, and how would I include external care partners?
Yeah, thanks for the question. No, there isn't, and we're very intentional about that because the Citus Health platform works best when all stakeholders are engaged, right? So multiple family members, nurses, social workers, medical directors, etc. So we really allow unlimited users to be on the platform and engaged. And it is really as simple as sending an invite through an SMS or an email. Takes less than 2 minutes for someone to get connected in to begin communication.
And thank you. And Maureen, a question came in directed to you, and that is, what resources are available for my team to best understand evolving CMS expectations?
Okay, good question. So Medicare has a website, obviously. You go to their website, they have an entire section for hospice. It's called the Hospice Center. And they have the conditions of participation. They have any new, what they call change request orders. So each year they come out with different changes and updates on the regulations for hospice. There's also, you can sign up for a newsletter called MLN Matters, and they email that to your email, and they list out any changes, they list out any resources, really good information, little snippets of information. So instead of trying to read the, I don't know, 4,000 page Federal Register that has the conditions of participation in it, you can look at that. That state operations manual, the guidelines for surveyors, that's also available online. You can download it in a PDF to your computer, and then you can just look up things as you need it. So Medicare has a lot of information. Also your MACs, Palmetto and NGS and CGS. I have to say CGS probably has the most user-friendly website. So even if they're not your MAC for Medicare, you can go on their site and get a lot of, just type in what you're looking for, like certification narratives, and they will have examples of narratives for your doctors to follow on writing the CTI. So all kinds of information on the web.
Thank you so much, Maureen. And another question has come in for Melissa, and that is, does the Citus platform automate the after-hours triage function in any way?
Yes, it sure does. So we have something called a message routing schedule, which will really mimic, a provider's on-call schedule. So, for example, if a family caregiver were to send a message out, that message would route based on who's on call, so that that situation that I described and Maureen described about the nurse in the car getting messages and phone calls really can be prevented, right, through the message routing to the right person depending on the time of day and depending on the day of the week. And then further to that, I mentioned this idea of message escalation. And that's another schedule that can be put in place. So if there's a supervisor, for example, who would normally back up the person on call, that message can escalate to that person as well.
Excellent, thank you so much. And those are all the questions that we have at this time. So again, Melissa, Stan, Maureen, thanks so much for being here. It's been great having you. And thanks to all of our listeners for joining us this afternoon.
Thank you.
Thank you.